Hey, good morning. I am Dr. Allison Bixler. I am a clinical and pain psychologist for St. Jude Medical Center, and I'm going to present this morning, Chronic Pelvic Pain, Is It All in My Head? And I hope to assure you by the end of this presentation that it is not. So let's go ahead and get started. So I'm going to start this morning with a definition. What is pain? So according to the International Association for the Study of Pain, or IASP, pain is defined as an unpleasant sensory and emotional experience associated with the actual or potential tissue damage or described in terms of such damage. Pain is always subjective. So you can see there that I've underlined that pain is always subjective. So what that means is that pain is different for every person and in every circumstance. That doesn't mean that it's not real or that it's in your head or psychologically created. What that means is that it is something that has a lot of different factors involved in it. So I'm going to tell you a little story that I call the parable of the boot. So it's kind of a famous, well-known story among clinicians who work in chronic pain. And it's a story about a gentleman who came into the emergency room with a nail through his boot. And as you can imagine, having a nail through his boot, he was in quite a tremendous amount of pain. But then, interestingly, when they took off the boot, they found that the nail went straight between his toes. So how do you account for all the pain that he was feeling? Was it not real? Well, we would actually say that it was very real. So actually what happened is that when his brain saw the nail go through his boot, through his eyes, so from a sensory perspective, when his eyes looked down at his boot and saw the nail go through, his eyes concluded that the nail was through his foot and therefore created the sensation of pain. And so we'll talk a little bit more about how that happens, but it explains a little bit more about how pain works. Pain is actually a neurological experience in the brain. It is not something that happens in the body. So we'll talk a little bit more about how that happens, but that's often a surprising story for many people. So to kind of explain a little bit more how that works, I want to show you something called the biopsychosocial model of pain. So the biopsychosocial model of pain is the currently well-accepted model for how we understand pain in healthcare, as well as in science and research. So the biopsychosocial model is shown through this diagram here. And basically the biopsychosocial model shows how pain comes from all of these different factors. So of course you have on the top there, you have the physical or the biological. So yes, you'll have things like tissue damage, like illness, like injury. Those things very frequently, most of the time, do play a factor. In the case of the gentleman with the boot, it did not, but most of the time it does. So when you have things like chronic pelvic pain, most of the time you do have something like illness or injury playing a factor in the pain. But along with the illness or the injury, you also have things that contribute to that pain experience, things like the psychological, like your mood, like your thinking process, how you're experiencing the pain and how that is filtered through your thoughts and your emotions, as well as things in your environment, like your relationships, like your living situation, like you work, if you work, all those other kinds of things. And you can see from all those arrows that all of these things come together in interactions to contribute to how that pain is experienced. And what happens is that your brain takes all that information together and processes it to determine how pain is experienced, not only how severely, but what the quality of the pain is like, all of those things. So this is probably sounding pretty complicated. So let me try to break it down into something that is a little bit more maybe approachable. So I often tell patients what I call the hunter-gatherer story. So now in modern days, humans we live in a pretty easily survivable environment, but our bodies were not designed to live in the kind of environment we live in now. So the kind of environment that our bodies maybe were more designed to live in was the kind of environment they lived in when maybe we were hunter-gatherers. Same humans, modern bodies, but back in a more ancient time. So let's say you're a hunter-gatherer. You're out and you're hunting and you're gathering and you break a leg. Well, a broken leg, that's a physical injury, and a physical injury that is significant enough that it should hurt. But that's not the whole story that your brain needs to know to tell you how bad a trouble you're in relative to your chances of survival. And that's actually what pain is about. Pain is supposed to tell you how bad a situation you're in relative to your likelihood of survival. And it's supposed to motivate you to try and do something to increase your chances of survival. So here you are and you have a broken leg. Okay, that's a problem. That decreases your chances of survival. But there's going to be more to the story that your brain needs to know. How did you break your leg? Did you break your leg because you stepped in a hole, or were you attacked by something? If you stepped in a hole, the hole's done its damage. It's probably over for now. Holes don't do anything else once you've stepped in them. Now, if you were attacked by something, that might still be a problem. That thing might come back and it might keep attacking you, and your brain needs to know that. So it might amp the pain up a little bit more for that attacker. Other things your brain needs to know are things like, are there other people around who are going to take care of you while you're healing from this broken leg? Is there food around? Are those people, is there a good hefty food store in place and reserves to keep you fed and warm while you're healing from this broken leg? How are your relationships with these other people? Maybe they're just going to leave you there to sit and starve while you're healing from your broken leg. So you can see that all these different factors kind of come into play in your brain's analysis of how bad actually this injury is in terms of your likelihood of survival. And so it's not just the broken leg, it's a lot of other things. So one pain really isn't just like another. It is different all the time. And your brain goes through this moment by moment by moment analysis on how bad a situation you actually are in. And so even if your physical state doesn't change, your emotional state can change, your relationship state can change, your environmental state can change, all sorts of things can change all the time, and so does your pain. So let's connect this a little bit with the nervous system. So this is a basic diagram of the nervous system. It shows the central nervous system, which are your brain and your spinal cord, and it shows your peripheral nervous system, which is basically everything else. So your central nervous system is the control center. It's the brain and the spinal cord, and that's kind of what we would call like the superhighway that sends information back and forth from the rest of the body. So as I was talking about before, the brain is what analyzes all that data that comes in both from the body and from the rest of the world. And things like thoughts and emotions are the brain's sort of analysis process. And then the peripheral nervous system is gathering information from the rest of the body as well as from the environment. So things like your eyes and your ears are gathering environmental information, while things like your nerves within things like your legs are gathering information about how well your muscles and other things are doing, and your organs are doing, all those other kinds of things. And so kind of illustrating the difference between the caveman and the boot man, or I'm sorry, the hunter-gatherer and the boot man. So if you take the man with the boot and you were to give him an epidural, and you cut off his nerve signals right here at the neck, right? Well, he's not getting any nervous system stimulation. So the superhighway from the central nervous system from the spinal cord is cut off here. So he's not getting any signals, but his eyes can still see the boot and the nail going through it. And so he still felt pain. But like when a woman goes into labor, The epidural cuts her off at the waist and she doesn't feel any pain, right? Because she's not getting the sensory feedback from, even though there's a lot of physical trauma going on below her waist from delivery. And so you can start to see sort of the difference between what the brain is concluding in one situation from another. So this is a picture of the Croods. I think that it's a really funny family and a really funny movie, but the reason I'm bringing up this picture is because on the far side, you see the old grandma. And she's standing there and she's looking very fierce and she's holding, I think, a club. And she's not looking like, despite the fact that she's quite old, she's not looking particularly impaired. She's not looking like she's in a lot of pain. And so what's interesting about that is if you think about that biopsychosocial model, there are good reasons why she wouldn't be in pain. She's got her family around her. She seems to be well loved and cared for, and she certainly seems confident of her ability to take care of herself. But what's interesting is that most people, once they get to a certain age, particularly older people, if we do imaging on them, things like MRIs, we do see pathology, meaning that we do see problems, for example, on their spine that could be correlated with pain. In other words, there aren't big differences between people who are reporting pain and people who aren't reporting pain on things like their MRIs, which suggests that the big difference are things like those other factors, are things like how alert the brain is to those other factors, how sensitive the brain has become. Okay, so now that's what we're getting into here. So what differentiates people like Mama Crude, I think that's what she's called, but from say, what differentiates someone who does develop chronic pain from someone who doesn't? So women with chronic pelvic pain, interestingly, are much more likely to also have other chronic pain problems, things like fibromyalgia, IBS, other problems related to chronic pain. And what that suggests, based on the research, is that it's very likely that their central nervous system has become hypersensitized. So if you remember from before, the central nervous system is the brain and the spinal cord. So the brain and the spinal cord, what can happen over time, if you think back again to that biopsychosocial model, is if things keep happening, whatever stressors they might be, whether they're physical stressors or emotional stressors or environmental stressors, but whatever combination of things keep happening, the brain and the spinal cord neurologically can become hypersensitized. And what that means is that they become kind of like a fire alarm that becomes too sensitive. So imagine that you're in your kitchen and every time you cook, the fire alarm in your kitchen goes off. Now it's supposed to go off when there's an actual fire, but if it's going off every time you cook, it's oversensitive. That's similar to central sensitization in chronic pain. So what central sensitization means is essentially the central nervous system, the parts of your nervous system that monitor and control everything else, they're essentially turned up too high. They hyper react to everything, to all sorts of stimuli, meaning that you react to things that are not painful as if they were painful, or to things that are not dangerous as if they were dangerous. So how can this develop? So one way to think about it is relative to something called the fear avoidance model. So early experiences of pain, and they can be anything. So it could be something like sexual abuse. It could be something like a traumatic birth. It could even be something totally, relatively benign, like having just a medical condition that causes pelvic pain. like very painful periods. It could be something very, very benign. But what happens is that over time is that the person can start to anticipate pain or fear pain. And then what happens is that can lead to something we call catastrophic thinking. And that anticipation or that fear and that thought process, remember that the brain, all thought and emotion occurs in the brain. It actually has neurological weight. Thought and emotion is real, it is neurological. And what happens is, so that turns up that volume in that part of the brain. And then that heightens the alertness of the central nervous system. So when that happens, then that makes pain more likely. Then those situations when pain can happen become avoided. So let's say, you tend to have pain with sex. So then sex becomes avoided, or when you have sex, you become more vigilant, you become more alert, more aware, more concerned. And then when that happens, you have your neurological system, your central nervous system becomes more alert, and that makes pain more likely to happen. Then the pain becomes worse as a result of these combined processes. So things happen like the nervous system becomes more alert, it kind of becomes more turned up. So think about that fire alarm again. But then also things happen like your muscles tense. So if you think about like when you're nervous or when you're anxious or when you're stressed, most of us will notice like after a stressful day, we go home and we notice like, we'll kind of notice relaxing. Well, yes, because your muscles are tense. That happens even when we don't notice. It even happens to smaller degrees when we're not noticing. And one of the things that happens with chronic pain is you have this long-term protracted muscle tensing. And so those things can compound over time and can also contribute to that nervous system problem that contributes to chronic pain. And then, of course, you also have the issues with declining skill set. Things like sex that's a skill set. So if you're not practicing, then that becomes harder and harder to do. If you're not communicating with your partner, that becomes harder and harder to do. And so those things start to deteriorate with time. And so then you start to develop some of these other factors that become associated with chronic pain, like low self-worth or low self-efficacy, feeling like you're not as good at things or not as able to deal with things that are related to the pain. The catastrophic thinking can be worse. You become more and more alert or hypervigilant to situations that might cause pain. So one thing that happens a lot with pain is that you become more alert to your body in general. And so things that you might have disregarded before, you become more aware of. And then the problem with that too is that if you become more aware of them, that can create a self-fulfilling prophecy. You can avoid activities that might be associated with pain, and that creates some kind of a smaller and more constricted life. And then, of course, things like depression and anxiety can develop. Even post-traumatic stress reactions are a reality. So moving on and talking about treatment, many people don't like to talk about things like psychology and cognitive behavioral therapy when it comes to chronic pain, because they feel like that reinforces that it is somehow a psychological problem. Now, I hope to have kind of emphasized here that this is really it all is a biological problem. There is no such thing as a difference between the mind and the body, that those two things are one thing. Neurology and psychology, those two things are one thing. Cognitive behavioral therapy is really just a way of getting the brain involved in its own healing. Scientifically, cognitive behavioral therapy has performed as well or better than surgical interventions and a lot of medications. It tends to last longer. In other words, it's more durable than a lot of other interventions for things like sexual functioning and pain severity. So basically, cognitive behavioral therapy is a form of psychotherapy or talk therapy that you do with a licensed psychologist, which is usually a doctoral level counselor like me, or a master's level counselor. If you're working on chronic pain or chronic pelvic pain, I strongly recommend you work with a pain specialist as opposed to a generalist counselor. And what you're doing essentially is you're working on negative patterns of thinking and behavior that affect your health and your life. So you identify those thoughts and emotions that can kind of start to set off that cascade of events, and work on just establishing better ways of coping, increasing your self-efficacy, and reducing your symptoms. It's very proactive. It's very goal-oriented. And as I say, it works. It works very well. It's not it's not a new age sort of thing. It's very, very heavily scientific, and it's very effective. And then the last recommendation I would make for anyone who's interested is the St. Jude Chronic Pain Program, which is an interdisciplinary program that teaches patients to manage their chronic pain and improve their functioning and quality of life. So the St. Jude Chronic Pain Program has been around for about 40 years. Chronic pain programs that are interdisciplinary, meaning that they have all of these different treatment professionals under one roof, are sort of the gold standard for treating chronic pain conditions. There are only a handful of them around the country. We are the only one that I know of in Southern California. And our team consists of pain physicians, a pain psychologist, myself, a physical therapist, occupational therapist, a biofeedback specialist, and a pharmacist. And basically what we're working on is to identify those biopsychosocial factors that are contributing to and possibly maintaining your pain, and teaching you coping strategies, lifestyle changes to try and help you to manage it more effectively so that you can improve your quality of life. We look at pain much like any other chronic health condition. So we're not trying to get rid of it. We're not trying to cure it, but we are trying to teach you how to manage it in such a way that you can maximize your quality of life, by teaching you effective changes that you can make in order to cope with it, and understand it better. So if some of the things that I've talked about in this presentation are helpful to you in understanding the pain a little bit better and making it make sense, the chronic pain program would take you even further in that direction. Thank you so much for taking the time to listen to this presentation, and I wish you the best in the future.